SABC's Full View. Now, the Board of Healthcare Funders of Southern Africa has welcomed the proposed amendments to the National Health Insurance Bill and the Medical Schemes Amendment Bill announced by Health Minister Dr. Motsoaledi today. The Minister reiterating his commitment to a national health insurance, which will mean that the working population contributes according to their earnings, and there is basically universal healthcare in South Africa, which benefits the poor that cannot currently pay for medical aids, for health insurance, and are not necessarily being treated by public hospitals. The board represents 45 medical aid schemes, administrators and medical care organizations in this country. To discuss, we're joined by MD for the Board of Healthcare Funders, Dr. Mothudi. Thank you for being with us, Doctor. So you're welcoming this, even though the medical aid schemes are in the line of fire, stand to lose drastically here.
I think first we have to see where the real focus is. The focus should be on the beneficiaries or the recipients of healthcare. It's not that the private health sector has been without challenges. We've been for a long time decried the issue of escalating costs. The ordinary person on the streets has to fork out a lot of money in terms of contributions every year. So the private sector itself is under a lot of pressure. And if we continue on the current trajectory, we will see a lot of schemes actually collapsing.
Okay, but the idea now is that some of the money going to the schemes will actually go to government to fund the national health insurance. So that is a threat, do you agree?
We understand that the funding model is yet to be finalized. And we also know from what the minister has said that there is an interim measure where schemes will exist alongside the implementation, what he calls phase 2 of the NHI Bill. So we do accept that there will be massive changes, but as I say, I think we have to keep in mind what the purpose is. In education, previously we've talked about the missing middle, for example, of those people who are working in our sector but cannot afford medical schemes. So all schemes are actually intent on having more people getting access to healthcare. And if our strides towards universal healthcare coverage should include collaboration with government on some projects, we welcome that.
I agree. Universal coverage is an amazing goal. From your perspective, are you getting an idea of the scope in the end for private medical aid? So we see all over the world, sometimes you have a great national health insurance, but people are still willing to pay a bit more not to skip the queues or maybe see specific doctors that they want. Is that getting any clearer for you?
There will be some sort of hybrid formation we accept, in that the majority of people maybe that are on schemes now will find health care within the fund, but there might still be a need for what is called complementary cover. But obviously these are things that we'll examine. The bills are out there for public comment, and we will be submitting our recommendations as we see it, so that we can increase access to healthcare. What
does the Medical Schemes Amendment Bill mean for you right now?
There are many elements that we've looked at. I think the first one is financial protection of members in terms of core payments. We have been over time unable to ascertain exactly how much the out-of-pocket expenditure is. So the first amendment that was announced was abolishment of the core payments, which we think is a great idea. Obviously the detail has to be fleshed out, and we will look at what is recommended from the government side.
So explain that. So doctors will have to say this is the amount and this is what the medical aid will cover, and it's the same thing.
Yeah, earlier discussions were around setting some sort of tariff, as was done previously. But obviously, without examining the details, we won't be able to say, is that the intent? The second thing could be schemes should cover whatever is invoiced with them. We have to be careful about protecting the finances of the scheme. So there's possibly many permutations to that particular end.
Yeah.
And we should not look at one singular amendment. Hand in hand with that is the issue of prescribed minimum benefits. And that has for a long time plagued schemes in terms of their projections when they look at budgeting. So if you remove prescribed minimum benefits, already there is some lowering of expenses for schemes. So we'll have to look at all the amendments in total.
Do you take responsibility? The idea is that medical aids can come together and they have huge negotiating clout. But that clout has not brought down the costs. They keep on being hammered on about the high costs of medical care in South Africa.
I think it's 2004, the Competition Commission said schemes cannot do that. So schemes have not been able to negotiate tariffs because they would have been taken as collusion. Now what it means is that a smaller scheme, let's say with 10,000 members, will find it difficult to negotiate favorable tariffs with the hospital group. Now with the tariffs that are likely now to be legislated, maybe in the same way as pharmaceuticals were in 2003, it might give relief to schemes, but the detail of course will be seen later.
And then it actually takes away the clout of the big guys, maybe like Discovery, and puts everyone on an even playing field. Is that correct?
Yeah, obviously we'd like to see the beneficiaries benefit, and you shouldn't be prejudiced by which scheme you belong to. So everything that we'll be looking at is to what extent will it serve the health citizen or the man on the street.
Yeah. Tax rebates, it sounds like he wants those to go. So if you pay for a medical aid insurance or to a medical aid scheme, you get some tax back. He's saying that's basically penalizing the poor. Do you agree with that?
There are a number of issues that the minister highlighted in that regard. I think the first thing he talked about was the funding from the state for government schemes, and I think that forms the bulk of the payments that they will consider to put in the fund. Obviously, there will be some other tax implications because the fiscus as is currently will not be able to fund the requirements.
If you lose those tax rebates, that makes it more expensive for the people who are paying for medical aid. So are you expecting a drop-off of members?
The drop-off, as you call it, will be into the fund, as we understand. So the majority of services that people are now buying from schemes would be available through the fund. So if people are unable to buy complementary cover, which we understand might be for discretionary healthcare services, it might be either here nor there, because those services would actually be available through the fund, where we are told that at point of service there will be no financial outlay.
You're talking about the government employment medical scheme now, GEMS, that's under one of your members. He was also talking about that, saying it's private healthcare for public servants. So it's tax money is going from the public coffers back to private healthcare. However, has there been much of an alternative? What do you think of what he was actually saying there? I mean, if public hospitals worked well, public servants would be able to walk into public hospitals right now. We haven't fixed that part of the building block yet.
The whole intention of universal health coverage is actually to fix that, in our understanding. If I'm on medical aid and I have an uncle, for example, who's not on medical aid, any expenses that accrue as a result of his needs still come back to me. So we have to look at the issue of access. Is the proposed fund going to increase access? Will it improve quality? And I think what the discussions were around this afternoon was that you cannot wait until you fixed the problem. Introducing universal health coverage is actually part of the solution to fixing the quality issue.
But why don't we fix quality first? Some would say, why don't we get the public hospitals working first? Why don't we make sure that the NHI pilot projects work first?
There are many other issues. I think people will cite issues of governance. People will cite issues of management. So in terms of focusing on quality, you cannot say, I'm going to fix 1, 2 that relates to quality without looking at the other problems. So in my opinion, these things can be done in tandem. You do not have to fix one issue and then go to the other issue. One of the amendments that he proposed, for example, are around governance, even how we govern the schemes, that we need to have people who are appropriately skilled to make sure that the entities that we run are properly formulated and well run.
All right, thank you for your time this evening. So medical aids under the banner of the Board of Healthcare Funders, saying that they're on board with the changes, with these steps closer and closer, which we are getting hopefully in the mind of the Health Minister towards a national health insurance in South Africa. Dr. Mothudi from the Board of Healthcare Funders. We'll take a short break. We'll be back.